Combined retinal detachments in advanced proliferative diabetic retinopathy. Tough scenarios. Understanding and approach made easy. Traction and combined retinal detachments are manifestations of advanced PDR, with severe vision threatening complications needing surgical interventions with varied success rates. The presence of the rigma in a case of combined RD changes the morphological aspect. The progression gets faster with pigment dispersion and other features of PVR. The configuration of a CRD is more bullous than a TRD. The fibrovascular proliferations in the above case are firmly adherent with a poor highlight separation anterior to the proliferation, which can make the dissection difficult due to poor counteraction. There are also seen areas of subretinal pigment dispersion as shown with the arrows, which eventually manifest at different grade of PVRs. The star point out the area of trough, which can be used to initiate the dissection by dissecting the hyaloid phase after peripheral truncation. A typical segmentation and delamination are preferred in case of TRD. A good plane and an easier dissection is possible due to attached retina. A good plane is extremely important also due to the flat nature of proliferation. A highest cut rate and a low suction is preferable to avoid iatrogenic breaks. Whereas in case of CRD, the detached retina makes the dissection difficult. This case highlights membrane dissection using the cutter alone. Care, however, should be taken to identify the areas of firm adhesion so as to prevent iatrogenic breaks and further interrupt complication. Cutter can also be used alone in initiation of membrane dissection. Dissection of the elevated prolifs using the trough in above case of CRD makes it easy to complete the entire prolif removal. Second membrane, if any, should also be removed and dealt with. The above case demonstrates the switch over to bimanual dissection. The initial membrane dissection and achieving hemostasis at the disc is extremely important for a bloodless field. One can notice iatrogenic break and sudden gush of sclerin inferiorly. A superior proliferation, however, if firmly adhering, wherein a chandelier-assisted dissection had to be used. Bleeders during bimanual dissection can turn out to be messy. A high degree of anticipation of bleed helps in preventing and tackling the same. A fluid-fluid exchange decreases the turbidity of the subretinal fluid for faster settling of the detached retina. The above video highlights the difficult hyaloid separation in case of chronic CRD with subretinal bands. A cutter dissection alone was done in this case. The retina getting bullous can be noted during the instrument exchange. One has to be prepared for such intraoperative challenges. A valve cannula system and preparedness helps in closing the case in a desirable way. Membrane peeling in a bullous retina might get difficult, but the vitreous separation in these cases has to be used to a surgeon's advantage. A proper peripheral dissection also is extremely important in bullous retina. In cases with dense and severe proliferations in CRDs, it would be worthwhile to start the case with bimanual dissection. A careful dissection with forceps and scissors or combination of instruments including the cutter can yield better results when used at the right time. A care has to be taken to achieve proper hemostasis and to avoid excessive pull on the retina. A TRD with macular hole can have flat proliferations and firm adhesions. A careful segmentation and delamination with care not to apply traction over the macula can yield better surgical outcomes. An inverted ILM peel in such cases may be preferred for successful hole closure. In the cases of CRD with subretinal bands close to the macula, the subretinal bands have to be removed after total membrane dissection, taking care not to inadvertently damage the macula. Perfluorocarbon can also be used judiciously to stabilize the posterior pole after tackling the preretinal membranes. The above case shows the importance of early surgery as the patient presented with subhyaloid hemorrhage, fibrovascular proliferation over the disc and supratemporal region. On delaying the surgery, the patient presented with combined retinal detachment and later on leading to neovascular glaucoma. The above case depicts a treatment-naive combined retinal detachment, at present with a good surgical outcome, emphasizing the importance of proper identification of dissecting planes. To conclude, it would be apt to say that though cases of CRD can be extremely challenging, a proper understanding of the presentation and anticipation of the possible difficulties would definitely result in a better surgical outcome. To name a few, early surgery would diagnose cases of CRD to prevent possible PVR changes, valve cannulas to prevent bullous detachment intraoperatively, hierarchical dissection with identification of plane, and low threshold to shift to chandelier assisted bimanual surgery, and fluid to fluid exchange decreases the turbidity of the subretinal fluid for faster settling of the detached retina are take home points. Thank you.